I think I have put this talk together for, it's mostly an introduction, so I hope that that's useful. Sounds like that's really. So let's get started. It's going to be more of a case-based work, and I first want to acknowledge that a lot of these slides have been contributed by Miguel Hernan or adapted from his book that's going to come out this year, Causal Inference for him, and Jamie's Causal Inference book. So any on the slides are my own, although I've looked them over, so hopefully everything's correct in there. It's on WebEx, but okay. I don't know if this is, if you're aware, but the Causal Inference book is available. There's lots of chapters that are freely available on Miguel's website, and I highly recommend downloading and keeping them, because even though they may change here and there, they're just excellent resources if you want more in-depth information about these types of methods. Like Causal Inference on Facebook and get updates on the book and any new kind of things that that group at Harvard is working on. Our case study today is going to be one of my thesis papers, which looked at long-term effectiveness of highly active antiretroviral therapy on survival of perinatally infected children in a linear follow-up study. See how old this study is, since I'm calling it highly active antiretroviral therapy. We don't call it that anymore, call it CART or ART. But again, this is a long time, but it's a good, I was able to, make a thesis committee, and this example was a prime example of to use inverse probability weighting, because it was a longitudinal study and through it. And so you can see why it was important for us, this method, and why we could use more of our traditional methods, such as just stratification or regression, in order to a valid effect estimate. Again, I'm in the world of pediatric HIV infection. Just some background on that. There were randomized trials conducted in HIV-infected adults showed that HART, or highly active antiretroviral therapy, was highly effective in reducing mortality. However, the natural progression of HIV infection in young children born to HIV-infected mothers and infected themselves is different from adults. They've been infected during birth, and their viral load levels, so their HIV viral load levels, are persistently higher, almost 2 to 3 logs higher than adults for the first 2 to 3 years of life, and decrease to the steady state levels seen amongst adults after approximately 5 years of follow-up. So we have an open question. To analyze the adult trials to kids with HIV infection. Do you see like that, or do you feel we could potentially just say HART active in adults, let's FDA approve these drugs for kids? Right, we don't know. We just don't know whether we can generalize these adult trial results. So why do trials in kids, right? So there have been trials of HART in children, but they focused mostly on intermediate immunologic and virologic endpoints. So improved CD4 counts, decreased viral loads. There have been no long-term trials to look at mortality. And this seems to make sense, right? It's hard to follow up children for a long outcome, such as mortality. Randomized controlled trials are pretty short. And so to add the effect estimate, HART on mortality in this population has relied primarily on observational studies. So before I started my dissertation, there were 2 cohort studies on HART and mortality. One Italian cohort study that looked at triple combination therapy versus no therapy. So again, the comparative group is no therapy. And the hazard was 0.29, so protective for mortality. And there was an older US-based study that looked at combination therapy with protease inhibitors and therapy without protease inhibitors, and again, very strong protective effect of HART mortality So it seems to suggest that we should be kids, and it seems to be highly effective on improving their survival. So one round, that was around 2001, 2002, and all of those previous studies had ended follow-up in 1999. And we have more drugs approved for pediatric HIV, and so the antiretroviral drugs that were coming into practice. And so there were lots of changes in initial HART regimens over time, and here shows the trends in the different antiretroviral drugs over time. So you see that at the beginning of the epidemic, 1992 or so, the only drugs that were available were single nucleoside reverse transcriptase inhibitors, such as idovudine or 3D. And so this is monotherapy, which we favor very rapidly because it really was not effective. Therapy with two-side and reverse transcriptase inhibitors, and then protease inhibitors came in, which was a new drug class, highly potent, effective drug class. Optimal studies and adult trial results, and I showed you previous pediatric studies, showed that triple combination therapy was highly effective in reducing mortality. So that came increase in HART with PI use. And over there have been new drug classes. Nucleoside reverse transcriptase inhibitors, integrase inhibitors. So we, over time, longitudinally, improvements in drug therapy require us to reevaluate what we thought were old questions, right? Because are we sure that HART regimens are the same as newer HART regimens, right? So the question. So to try to answer this question in a observational cohort study, and ask the question, what is the effect of HART on mortality among perinatally HIV-infected children? Is this study question? Motivated, but is it a good study question? Would you be able to take this question that I posed to you and does analysis know exactly how to conduct analysis around this question? Or do you need more information, less information? Yeah.
I think it depends what your definition of HART. Are you interested in a certain regimen? Are you interested in any regimen? The non-specificity of what your treatment.
Exactly. These are all great answers. Absolutely right. This is too vague. Too vague of a question. We mean by HART. What is our outcome? Mortality, cause-specific mortality, overall mortality, or follow-up period, right? We can ask, well, who's your study population? Is it kids, older kids, teachers? What's the age range of our study population? Who's eligible to be a cohort? So again, epidemiologist, if I got this question, I would probably be asking a lot more questions to try to identify in detail what is my actual question. By HART, is it you were on HART and you stayed on HART? Is you were on HART and then I switched you off of HART? Initiating HART? What do we mean by HART, right? Do we take all users in a population, which includes incident users and point users? We actually define what we mean by HART, right? So Miguel and Jamie have argued that to formulate a really well-defined study question, a trial question, helpful if we can map it to a target trial. So a target randomized randomized controlled trial. So, for example, we may want to specify it a little bit further, and what is the effect of initiating HART? So among children who had never initiated HART before, the effect of initiating HART on their survival, right, versus not initiating HART. Again, so in this one, it's really just great to map it to a trial. What would we do? Who would be eligible for our trial, right? Let's take, if it has a favorite comparativeness question, we can try to map it to a target trial. Does anyone have one they'd like to share with the group that we can try to map to a trial? Diabetes? Who is my diabetes person? Okay, who would be your study population? Okay, type 2 diabetes, okay, over 40. And what would be your intervention? Okay, so have previously used aspirin before, or they're like new users? New, and a specific amount for room? Yeah, okay. So aspirin, let's just pretend that's enough. Okay. So our treatment strategies are, you have 2 arms? Okay, once a day? So one group today, baby aspirin, the other group, nothing. Follow-up? We're not talking realism right now, okay? Trial. Because there are certain study questions where we just can't do trials, right? Smoke, cardiovascular disease. There's no way we're going to randomize someone to smoke, okay? So, again, let's just pretend that everything is anything we want. Have an infinite number of people to randomize. Okay, so we talked about eligibility criteria. We talked about our treatment strategies. Randomize. Is that right? We want to randomize. And our follow-up period was 10 years. What do we cardiovascular disease? Okay, so no imaging or anything like that. True clinical events. Okay. And what is your causal contrast of interest? What is the effect of initiating baby aspirin, daily aspirin, initiating daily aspirin for 10 years on cardiovascular as defined by clinical events versus not initiating baby aspirin, right? Causal contrast of interest. Estimate a risk rate. Sure, okay. And once you have your eligibility, the treatment strategies, what are the arms that you're actually comparing? We're going to randomize, right? We'll talk about why randomization is so important. Follow 10 years, outcome, causal trust of interest, what is our effect estimate parameter that we're really interested in. So and flows just really nicely. It becomes just very easy once you know what your question is. So let's move on. All right, so case example. The solution for my study was 2 prospective cohort studies actually that were longitudinally sequenced in time. That prospective cohort studies of HIV-exposed children, both infected children and uninfected children, from 80 study sites in the United States. So when HIV exposed, their mom was HIV infected, so they were exposed to HIV in utero. And the goal was to assess long-term effects of HIV infection and in utero and postnatal exposure to antiretroviral therapy. 219 was a study that started back in the early days of the epidemic, 1993, and follow-up was till 2000, so it's very long-term. And then in 2000, the study investigators decided to open up enrollment into 219C, so they called it 219C. 19, so they called it 219C. And they opened up enrollment to infants that were not from previous trials. So 219 had only enrolled children that were in previous trials, like for antiretroviral drugs. So their mothers had been in trials before, and so the infants born to women in those trials enrolled in 219. 219, any HIV-infected child was able to enroll. And in these prospective cohort studies, I mean, they were very expensive, but also excellent data because they collected all sorts of clinical information from information, not just CD4s and viral loads, but all sorts of chemistries and hematologies. Did various neuropsychological assessments. Over time, there were tons of other laboratory evaluations done. So it's rich data source. So my question was, again, what is the effect of initiating HAART, right? So when I subsetted the study population from this larger source population, I ended up with 1,236 perinatal HIV-infected children from these source population studies between January 1st, 1996 and June 30th, 2006. And I only included those children who had never initiated HAART before, right? They would be the ones eligible for my trial. I've been exposed to HAART before because I don't want to include people who have started HAART and then failed, right? So, and with HAART, you are worried about resistance. So if I include people who started HAART and then failed, so they're naive when they are entering my study population, they're not in it. When entering my study population, they're more likely, if I give them HAART again, if it's the same regimen, they're more likely to fail, right, just because of resistance. And yes.
What about maternal treatment? I don't know. Sure. Sure. So, I mean, does that matter? Maybe if you randomize people, or
So you worry there's exposure to, say, therapy. Did it transfer resistance?
or did she get ABT during labor?
Right. So you have two options, right? You can say, let's think about it. Right? So I limited my study population from 1996 onwards, because 1996 is when, if you remember the treatment patterns over time, is when protease inhibitors came into practice. And so I wanted to include the time where someone was actually eligible to have the exposure, right? Before then, no one would be eligible for HAART. And so let's talk about that, right? In pediatric perinatal guidelines, between DED monotherapy came in early in the year, and the trial results of 076, which was prevention of mother-to-child transmission, which showed that giving didosine during pregnancy prevented, like, 75% or more of new infant infections. So a lot of moms, think about it, a lot of my infants and children would have had mothers who were already on these 076 regimens. So it's hard to restrict my population to infants who would not be exposed. Is that true?
Well, I think about women that are really high risk that come in not on therapy, not compliant, or come in with labor and get therapy. Or if it's HIV unknown, right? Absolutely. Would be a different, that baby might be really high level, and I don't know that matters.
Yeah, absolutely. These are all really important things to think about, right? So, so you have a couple options, right? You can say, in my design for this study, I'm going to restrict my study population to infants who were born, who were never exposed to, who were never exposed to antiretroviral therapy, right? And infants, I'm going to try to initiate HAART and not initiate HAART, like mimic my observational study for that. So I'm restricting my eligibility criteria, which is totally fine, and then I'm going to do that in the design. That is your choice. But then when we get to real world data, right, it's always like, do I have enough of those people in my population to actually restrict? Or I would have just enough variability in my exposure. Or am I going to observe enough outcome variables that may affect your probability of getting exposed and your probability of getting an outcome. And then besides, I'm going to measure it and try to adjust versus I'm going to be certain. Do you see a problem with using your study? Generalizability and transport.
Yeah, can you kind of use the word population here?
Yep.
You have a sample that sort of represent any population. These are very selective individuals that participate in the study. So what do you mean when you say population?
So the study population, you're absolutely right, right? So there's always when tomorrow's workshop is about selection bias, right? For those of you who are going to attend tomorrow's workshop, we're going to talk a lot about this. We're going to talk about selection bias. What do we mean? What study? Are they representative of my underlying source population, right? Like at the end of the day, do I get a valid effect estimate that not be generalizable, or do I have bias effect that it doesn't matter about transporting it because it's just bias, right? So when we talk about selection of your study population, you have one thing, which is generalizability, but before generalizability, we have to wonder, like, did we just introduce selection bias, where we even estimate a valid effect, right? I would argue that it's not so much about selection bias, but more about generalizability. Any effect measure that I get is able to appropriately control for confounding and bias, generalize it to other children with HIV.
Yeah, but I think it should be used in
sample.
Yes. Yes.
Sample.
Yeah.
There's a lot of statisticians, right? Let's say sample. So study sample. Is that correct?
No, I'm just,
No, it's fine. I think that's great. So study sample. That's a good word. Yes. What is the effect of initiating?
But the fact that maybe one patient was initiated by doing therapy for 1 month.
Right? What is the overall effect of initiating? Right? So if this is what would happen in a trial, right? So say we didn't have to rely on observation, right? To do this trial, look at the effect of heart, right? What is the population of children, 9 heart, randomized one group, randomized group to not start, right? Randomized trial. We don't worry about confounding, baseline confounding, right? You made a hazard. What is the causal context? If we analyze trial, right, as a what would be the thing, right? If I see heart, this is not an issue. Same thing, right? You may have issues in your trial about compliance. You might have issues in your trial about loss, right? Your trial goes standard, right? Intention to tweak, right? There's a thing. So analysis, we defined heart as the use of at least 3 drugs from at least 2 different classes of HIV therapy, and at the time there were only 3 drug classes that were in use. And as we talked about the subjects, we made this assumption, right, that subjects who initiate heart stayed on heart for the remainder of their follow-up. And right, there's many different types of antiretroviral drugs. I am not defining heart based on a specific regimen. I'm saying any 3 drugs from any 2 different classes of drugs, right? So I'm estimating the overall effect of type of heart regimen the providers chose, right, and mortality. It's true that maybe one heart regimen is better than another heart regimen with respect to mortality, right? That could be the case. Drugs are better than others. But the effect that I am estimating is the overall effect of all different types of regimens, right, on mortality. So my effect is dependent on the distribution of the different types of heart regimens in my study samples, right? Yeah.
Just to follow up on what they were talking about too, and I think in clinical trials, if you clinical trial with this, at least, you have your this at the clinic, and they are calling patients, and they're following up with patients, and patients tend to be a lot more adherent to their medication when they have that type of follow-up. So in a clinical trial, you get an estimate, which sometimes optimistic, because that's not what really happens out there in the real world. When you actually put this into practice, people go away and they're not being followed up. And so in some sense, these observational studies give you a more realistic view of what's actually going to happen, in the real world, I think.
Versus effectiveness. Right.
But did you have information on whether they were compliant or not? At least in a trial, you can look at that and see, like, if nobody was compliant because the regimen was so toxic, and you wouldn't know whether people didn't, you would know if 80% of people didn't take it. You would at least have that question that maybe some people weren't compliant. But if you don't have that data in an operational study, then you can
Absolutely. You need data, right, to be able to answer the question. But just follow up on that, right? So it was right? So say you're a randomized controlled trial, the drug was too toxic, right? People stay on it for very long, so they went off. Would you still be interested in the intention to treat that, or would you be more interested in a program?
intention to treat, because obviously people aren't going to treat it. But at least you know it if you have that data.
Absolutely. But it would be a trial, right? If you have a drug that you think is amazing, but nobody's going to take it, what's the point? You're not going to institute any type of policy that says take this drug, knowing that 80% were just not. Right? So in the intention to treat effect, right, is the true one that you want. It's the overall effect of this drug. Right? You initiate something, but over time people are just not going to take it. The overall effect is going to be null. Right? You're not see an effect. And the important one, that is the important one. Okay, so in this study was a maximum of 10 years until the last visit at which the subject was 5, so that's when it's censored. The last visit before 30th, so that's the administrative censoring. Okay, let's classify, so treatment strategies can be classified according to their time course. You can have point interventions, which are interventions that occur at a single point in time. So, dose vaccine, a traumatic event, the bomb, had once, 1-3, these are interventions. We just talked about intention to treat effects in randomized controlled trials are actually about point interventions. You have a trial that take the aspirin for 10 years, right? But the intention to treat effect is actually about a point intervention, right? Intention to treat, did you initiate that? Right? To treat effect is about a point intervention. And so you only interested in baseline confounding. You can also have sustained strategy, right? So interventions that occur at several times. So again, talk about that same trial. And let's not talk the intention to treat effect. But that trial could be about sustained interventions, right? Take daily aspirin every day for 10 years. That's a sustained intervention. Medical treatment, lifestyle, diet, right? So sustained over time, environmental exposures, and everything mostly would argue that most questions about sustained interventions, right? It's really hard to say, one event and let's look at the effect of that one event. Most of our questions about, nutrition, diet, physical medications, interventions, sustained interventions. Let's talk some of your questions you were working on. Can you identify, let's about the diabetes example, sustained intervention or a point intervention? Any other guys are working on? What was the diet, nutritional example? You think of one? Point intervention that maybe. A person who has an exposure for a short period of time seems to apply. Yeah, I would say that those might be sustained. Like when we think about pointed, we talk about a 1.1 day. Yeah, like the most extreme example was like this point intervention. Now we look at outcomes. Or a single surgery. Right. So many questions are mostly about right? It's the same. You can have someone who says, oh, maybe it only costs a couple of days, but what if the person decided not to take it for 1 day? Take a 3-day intervention, right? They take aspirin for 3 days. What if they do? It's kind of hard to think of a point. Most questions are the same. So it's hard to think about, right? Because it's not, we talk about strategy when we think about trials, right? Because in a trial, you're not going to randomize one. Right. So here we're more like, is there an association between disease and the long-term outcome? I would probably turn that question around a little bit. Say, if I if there's a way to treat somebody with gestational diabetes, right? Probably, and that may be my real policy question, right? If I could prevent this, or if I could treat it, what would be the effect for long term? This is not answer your question.
So like it's simple, like if you have a bloodstream infection, blood clot, right? And you have the population, you want to, so what do we say? IV is extraordinary, and then we can be in contact with there's only one time they go check the recommendation.
Intervention is actually calling the IV consult versus not calling IV. Yeah, if you're looking at the effect of just calling or not calling, then I would say yeah. That's my that's being analyzed. It's almost like being analyzed as an intention. Any other questions to talk out? Any questions of interest, anyone? Okay. Classify sustained treatment strategies into static strategies, which is fixed strategy for everyone. So example, treat with 150 milligrams of daily aspirin during 5 years, and initial heart and forever, or dynamic strategies, right? A dynamic strategy is a strategy that assigns different values to different individuals as a function of their evolving characteristics. So, for example, aspirin if the patient's diagnosed with coronary heart disease, and stop it if they have a stroke, right? Hemorrhagic stroke. If I'm interested in evaluating initiating heart as a dynamic strategy, I can potentially ask the question, what is the effect of initiating heart CD4's drop to 350 versus initiating heart if I lower the threshold for CD4 count? So I'm going to compare initiating heart at 350 versus initiating heart at 200. Right? That is a dynamic strategy because I'm waiting for subject CD4 to drop and randomize you. Right? At 350, I'm going to wait. CD4 is drop 100, and then I'm going to initiate heart. So dynamic strategy. So the workshop this afternoon about inverse probability for dynamic strategy, and this workshop is about static strategy. So we'll talk about a fixed strategy for everybody. So about randomization. So causal inference methods are methods that emulate randomization. So when someone talks about causal inference, they're talking about, how do we emulate a randomized trial with observational data? And so, randomization is so important. Why hold randomized controlled trials as the gold standard? You know, issues, but why is it that was the gold standard? Randomization is so great. Okay, so lack of confounding at baseline. So both measured and unmeasured, right? So if randomization works, right, then we assume that both, if we have two arms in our trial, that whether any variable is equally, any prognostic variable for your outcome is equally distributed in both groups, right? As a way to adjust for confounding. But looking at baselines, right? We know at the randomization, if randomization works, that those two groups have the same probability of the outcome. With randomization, it's great. Causal inference methods is going to try to emulate randomization. How about how we define an average causal effect? Right? So I'm familiar with the concept of the counterfactual. How do you know about the concept of counterfactual? Great. Counterfactual. Person, right? Each individual person has counterfactual outcomes if we have a binary treatment, right? You have your outcome if you're treated, and you have outcome if you are not treated. Right? Interested in the causal effect of treatment, right? And we could observe the actual outcomes for an individual. We would say that the individual causal effect, if this individual causal effect, if your counterfactual outcome under treatment is different than your factual outcome under no treatment. Do you agree? Right? You have both outcomes, individual causal effect. But we determine this individual causal effect except under like extremely strong circumstances, right? We go into a time machine and go back to the exact point in time, and and then try to observe both counterfactual outcomes, identify a individual causal effect. So you instead try to estimate an average or population causal effect. So what do you mean by that? Population causal effect is the expected value had everyone been treated, compared to the causal effect had everyone not been treated, right? The utilization had everyone not been treated. Say that there is an average effect of treatment, causal effect of treatment, if those two expectations are different. And estimate this average population causal effect with strong assumptions and observational studies. But in ideal randomized controlled trials, which we'll talk about, no assumptions, right? So let's talk about that. First, causation versus association. So what do we observe in real life, right? We have an observed population or a sample, and have some percentage of that population that's unexposed to treatment, and have some population that's exposed. This is what we have. This is real life data, right? So what is causation? By cause, we say, what would if the same population had been unexposed, so A equals 0, right? Everyone had been unexposed. What would have happened had everyone been exposed, right? Be causation. We have observed everybody's counterfactual outcomes. We would be able to estimate this. This is causation. What we in real life is association, right? What is the probability of the outcome given that you were exposed, or the outcome given that were exposed, right? Different causation, everybody was exposed versus everybody was exposed versus amongst those that were unexposed and amongst those that were exposed. So the counterfactual outcome here, probability had everyone had the exposure, is the proportion of subjects that would have developed the outcome Y had all subjects in the population received exposure value A. This counterfactual risk of the outcome Y, and this is unconditional marginal probability, calculated using data from the whole population, right? We haven't conditioned on exposure. We didn't say what's your outcome given exposure. It's everyone's exposed. As we talked about, causation would be probability the outcome had everyone been exposed, compared to probability had no one been exposed. We talk about the probability conditional on the exposure that you received. The subjects that develop outcome Y amongst those that received exposure value A. The risk of Y amongst those exposed over unexposed, and this is a conditional probability. Use a subset of the population. And we would say association is if this probability amongst the exposed is different from the probability that were unexposed, right? Versus marginal. All right, so let's talk about how we can estimate, right? We can estimate the average causal effect in an ideal randomized experiment. So why is that possible? And let's talk about what we mean by an ideal randomized experiment. A large or near infinite population where we know randomization is going to work, right? No loss of follow-up, full compliance, everyone's adherent to the assigned exposure, and double-blind assignment. So this is the ideal version, right? The years to treat effect is going to be your average causal effect. Now, go into randomization. So assume 2 exposure groups and untreated, and the membership in each group is randomly assigned, right? You flip a coin, you go in this group, flip a coin again, you go in this group. And the is you treat subjects in group 1 and don't subjects in group 2. So your probability of the outcome given your exposure is 0.57. Right? So option is instead of treating subjects in group 1, you decide to treat subjects in group 2 and don't treat subjects in group 1. What's the probability of the outcome given treatment? Absolutely right. Because the same, right? The probability of the outcome should be the same because you rate these 2 groups, right? So regardless of whether one group got treated, the other group got treated, the probability of the outcome should be the same. Do you agree? That's the same. Accomplishes, right? Because whether I give this treatment or this group treatment, it does not matter because the average probability of the outcome is going to be the same in either group 1, either group or group 2, given your treatment. Does not matter. It's independent. of your treatment assignment. Did you see that? Yeah? Okay. So membership is randomly assigned. The risks are the same. So both groups are comparable, or called exchangeable. Exchangeability is a consequence of randomization. Are people familiar with the term exchangeability? Yeah? So these are the primary assumptions of causal inference. So when people talk about exchangeability, they're talking about, it's kind of one of the words that's used as an assumption for causal inference. Exchangeability is when subjects in group 1 would have had the same risk as in group 2 had they received the treatment of those in group 2, right? The expectation of the outcome is going to be the same, regardless of treatment. So the risk of the treated equals the counterfactual risk amongst the untreated. If we had treated everyone in group, if we had treated everyone, so it was group 1, we treated everyone in group 1 and then not treated everyone in group 1. It would be the same as treating everyone in group 2 versus not treating everyone in group 2. So it's just of exposure assignment, the outcome is the same. And that's the same. The counterfactual outcome under treatment A among those that received treatment A is equal to the counterfactual outcome under treatment amongst those that didn't receive treatment A. The same counterfactual outcomes. So independent of your counterfactual outcome. So that's what it's saying. And there's the lack of confounding. Both groups are the same. So randomized experiment, the conditional probability that we observe, right, is equal to the actual probability. Isn't that awesome, right? Great. So with exchangeability, the conditional probability is the counterfactual. Or the associational risk ratio, comparing the probability of the outcome amongst the exposed over the probability of the outcome amongst the unexposed, is equal to the causal risk ratio. The probability had everyone been treated, the probability had no one been treated. There's exchangeability. So let's prove these are assumptions for causal inference. Why is the conditional probability equal to the counterfactual probability? So the probability of the outcome among is equal to the counterfactual outcome when A among, right? This is consistency. Well, do people understand what this is? So we have, amongst those who are treated, A equals 1, observe an outcome Y, right? So the probability outcome amongst the treated is if in the same group, if we had treated all of them, their counterfactual outcome would be the same, right? That's consistency. This is just logic. And with randomization, we actually achieve exchangeability. So we have the consistency assumption and the exchangeability assumption, which says the counterfactual outcome among the treated, the counterfactual outcome treatment among those that are treated is the same. Counterfactual outcome under treatment we're not treated. This is exchangeability. Equals the counterfactual outcome in everybody, right? So randomization. This is exchangeability. Both are the same. And so it doesn't matter whether I treat group 1 or group 2. It really doesn't matter. My expectation for the outcome is going to be the same, right? The difference is going to be treatment. And so identify a causal effect of treatment. And just this exchangeability is generally not true in the absence of randomization. So this is why we really like randomization. So randomized experiment association is causation because randomization produces exchangeability. And now method for causal inference. Hooray! We are in. We don't need to adjust for anything. We don't need to make any type of assumptions. Let's go home. we don't have infinite samples where everyone's compliant to everything all the time, and we don't have lots of follow-up. So real randomized experiments are not ideal randomized experiments, and there's no real clear-cut separation between real randomized experiments and observational studies. They're all going to have to make some sort of assumptions, right? So we have to worry more about confounding, right? And in real randomized trials, hopefully randomization works, so we don't have to worry about baseline confounding. But you have differential follow-up, you can have other issues in real randomized controlled trials that you're going to have to worry about. For example, in animal studies, we probably have to make more assumptions than randomized trials where we have baseline confounding and time confounding, but there's still things to worry about whether you're doing a randomized trial or an observational study. So are we at end? We can't do ideal randomized trials, and exchangeability, which is a consequence of randomization, is a condition for causal inference. Exchange is generally not an acceptable assumption in observational studies because that the exposed and the unexposed groups are generally not comparable, right? So individuals who receive a heart transplant may have more severe disease. In the HIV world, we usually worry about something called confounding by indication, where children who initiate heart may have more severe disease. So physicians are more likely to start children with more severe disease on a newer treatment, right? Because I think they're like you trying to do anything that you can to help them survive. So this is confounding indication. So if I just compared children who initiated heart in my observational study to children who didn't initiate heart, what would I see in terms of my effective heart? It's true, in my case example, that clinicians give sicker children heart. What would my crude effect, my crude average for heart? Would it be 1? Would it be above 1? Would it be below 1? What is your estimate? Okay. So my case example, right? If providers actually were more likely to provide heart, a triple combination, pregnant to sicker children, right? And so if I'm interested in estimating the effect of heart on mortality, right? And I'm just doing a crude association, estimated crude, what would my hazard ratio look like? Overestimated in what direction? Above. Conclude that heart is bad, heart is killing kids. That concludes, right, from my observational study. If I just association pretend it's a randomized control trial when it's not, right? I have confounding. Sicker kids are heart, and sicker kids are more likely to die. In an observational study, we're not going to achieve exchangeability, right? A condition weaker than exchangeability is to be able to say that we can estimate a causal effect, right? We know that the exposed and the unexposed groups are just different. They're not exchangeable. And randomization in an observational study. So this graph is about inverse probability, so there is hope. And to be able to try to estimate a causal effect from an observational study. And so what is this hope? So let's consider only individuals with the same pre-exposure prognostic factors, right? When we look at these subsets of individuals, we can say that those unexposed and exposed groups are exchangeable. So let's look at the CD4 example. Make it true that among the sickest kids, right, those with CD4 count less than 100, who received heart and those who didn't receive heart are the same. It could be true that within this subset of low CD4 counts, these and the unexposed are exchangeable. This is also a reasonable assumption, right? I decided to initiate heart, and the other provider decided not to initiate heart. But with low CD4 count subset, set, those two groups are exchangeable. And so, in another example, among individuals with an ejection fraction of 10%, those who do and do not receive a heart transplant may be comparable.
So is the exchangeability determined on comparing like factors and if they're balanced? Is that?
How do you do that, right? So we're saying exchangeability is, I'm not comfortable saying that exposed and unexposed groups in an operational setting, right? We're just not comfortable. So would we be comfortable if, for example, we subsetted the sample to those sickest kids, right, and compare heart and non-heart in those sickest kids? Would you be comfortable saying that those two groups are exchangeable?
That's a question.
Yeah. But are you more comfortable doing that than say the installation?
More comfortable.
More comfortable. Okay. Reasonable to assume that exposed and unexposed groups in that category may be reasonable. So we may hope to try to estimate a causal effect because we can maybe make some reasonable assumptions, right? So this conditional exchangeability, where levels of covariates, which we call L, exposed in subjects would have had the same risk as the unexposed subjects have been unexposed. Right? So conditional exchangeability, conditional on L, conditional on some covariates. We feel it's reasonable to assume conditional exchangeability. Factual risk is the same in the exposed and the unexposed within the same level of L. And randomization levels of L, right? Amongst the sickest kids, we randomize people to initiate heart and not initiate heart. Levels of L. There's no unmeasured or residual confounding within levels of the measured covariate. So we recently measured all the L's required to make these groups exchangeable. So the conditional exchangeability assumption, causation is causation, right? Levels of the covariates. And so now the method for causal inference from observational data that's assumption-free, right? We're making the assumption of conditional exchangeability, but relying on this assumption is not the problem, right? We were pretty, it's reasonable. It's a reasonable assumption, and we seemed pretty comfortable with it. So what is the problem? Going back to what you said. The problem is that we can't test this assumption. There's no way to test the assumption of conditional exchangeability. We just don't know if we actually did, and if we thought we may actually have not achieved conditional exchangeability, right? With randomization, we can hope, that's what we hope, randomization, an ideal randomized control trial, both measured and unmeasured covariates would be equally distributed, measured and unmeasured, right? In observational context, we have measured covariates, L, but what about the unmeasured ones? We don't know anything about them. And we make the assumption of conditional exchangeability, and it's often reasonable given what we know about our substantive area, but it's just untestable. We cannot test this. And this is why people, say that causal inference from observational data is just not possible. Right? Say this is, it's just controversial. Like you just cannot estimate a causal association from observational data. And because of this conditional exchangeability assumption, we can't do it, but we hope that we're doing the best that we can. And to get it as possible by using expert knowledge to enhance the plausibility of the assumption, and we can measure as many pre-exposure covariates as we can, right? Our confounders. We try to do the best to measure all of our confounders and then try to adjust for them. And again, inference from observational data, we can only hope that the exchangeability assumption is approximately true. We just are never sure, and we always have to acknowledge acknowledge the possibility of residual confounding. Right?
One quick question.
Yeah.
So you're talking about causal inference with a framework with a counterfactual. Is there any other framework to perform causal inference in which the assumption of exchangeability or conditional exchangeability is not necessarily the driving force?
No. Causal inference requires a couple of assumptions, and this is the primary. It's the only way to be able to say that we can estimate a causal inference.
So even those additional assumptions would be the most important because we have a few assumptions here. Which one is the most and cannot be reached in observational study?
Which assumption? So we talk about conditional changeability,
Yeah.
right? That's one. We talk about consistency. The other one. Your question is about the conditional changeability expression. And the question is,
Yeah. In the conditional exchangeability, we have a few points here, right? Among those assumptions, among the conditional exchangeability, which one is our point?
so conditional changeability, there's only one definition, right? Which is within levels of your measured covariance, the exposure.
Yeah, the main thing nowadays, most of the time when we talk about for anything, we're talking about unmeasured covariance. I think that's the main thing, right? Because we don't know that.
We don't.
Yeah.
And we have to be okay with it.
Yeah.
And at peace with the fact that we don't know anything about what we didn't measure in observational studies.
So that is the main problem.
But it's very difficult to say that you're going to perform a causal inference analysis in a vacuum, which means there's no evidence that you're trying to whatever test you get from your study. It's not like it's going to be, at least it's not going to be a discovery phase of a particular issue.
Right.
This is additional sources of evidence that you're developing.
Exactly. I mean, we can help our hands, and we're just not comfortable with the conditional exchangeability assumption in observational studies. But we do don't do we? Right? So I think we have to be willing to make assumptions given our best expert knowledge. Otherwise, I don't know what the other alternative is, right? So we can just throw up our hands and say, well, we can't answer. Or we have to try to make this assumption as plausible as possible, right? And we do that because we have our scientific background, we have our collaborators, we know something, as our colleagues have said, that it's not the first thing that we do, right? There's a lot of exploratory studies, a lot of studies, substantive studies that help us expert knowledge, right? That help us identify the L, the confounders that we need to target in our and so you have to make this maybe really strong conditional exchangeability assumption, but the alternative is to do nothing.
So there's one thing I'm unsure of. They talk about the sensitivity analysis. Does that address any of this, like the uncertainty in the assumption?
You know, like I said, I'm not a methodologist. From my understanding about sensitivity analysis, the way that I try to use sensitivity analysis is to say, okay, I guess that I could, right, adjust for confounding, but I may have unmeasured confounding. How much unmeasured confounding would have to exist for me to change my conclusion? So if those past Italian cohort studies, right, the whole thing, like 70% decrease in mortality, right? That has, I mean, you would have to have a lot of confounding to make that protective effect of heart go away. Can you think of a group of another set of confounders that would make that go to null. Right? You guys are just like really serious. I think you forgot that it's really serious, in fact, to make that association. So that's what I think about when it comes to sensitivity analysis, right? Like how much confounding do I have, residual confounding do I have to make my conclusions go away? That's what I think about when I think about sensitivity, but there may be others. Are we cool with this conditional exchangeability assumption? Let's talk analysis. There's many methods to compute causal effects. Biostatistics classes and epidemiology classes, we can stratify, right? Our confounders, we're trying to achieve conditional exchangeability. We can use N, we can match in the design, and we use inverse probability weighting, which is what we're all here to try to learn about. But all methods assume exchangeability, right? So they have been running our regression models, adjusting for confounding. The assumption behind what you have been doing and have been doing our whole time, and when we adjust for confounding, is achieve conditional exchangeability. That is the assumption that we have been making when we try to adjust for confounding. You may, but that assumption that we have been making. All right, choose what method we should use for analyses, right, and for different questions. So comparisons of strategies involving point interventions, right? So a single destination, calling the ID consult versus not calling the ID consult. And methods are going to work. You have to worry about baseline confounding, use regression. You can use your favorite method that you like. If all the baseline confounders are measured, you're good. You're good to go. Strategies, generally, only causal inference methods work. That's because in sustained strategies, we have time-varying treatments, right? Treatment every point in time. And varying treatments imply that there may be time-varying confounding. In the context of time-varying treatment and time-varying confounding, we have this possible treatment confounder feedback that I will try to relay to you, hopefully clearly. So text. Conventional methods such as regression and stratification may introduce bias if we have all of our measured covariates. This is now the reason why people are saying we should be using causal inference methods such as inverse probability weighting, because we live in a world of sustained treatment strategies. We are interested in sustained treatment strategies. And when we're in this world of sustained treatment strategies with time-varying treatment and time-varying confounding, our traditional methods for adjustment just don't work. So, case example, I look to see when HART was initiated over time, right? And you can see that it's not like everyone initiated HART at baseline, right? So, like at the time point, everyone on HART, or there was a subset on HART, and then there was a subset that just remained off of HART. People over different time points, over follow-up. So there are differences as to why someone initiated in month 1 of follow-up versus why someone initiated in month 50 of follow-up, right? There could be a difference as to why. And so this time we have time-varying treatment and is initiated at different points over time, and then we may have time-varying confounding, where the confounders are changing over time, which makes treatment at that time. So how many of you are familiar with DAGs, direct acyclic graphs? Most people have never seen a DAG in their life. Okay, 2, okay, all right, so I'd like to explain. So directed acyclic graphs are a good complement to causal inference because they try to present a causal framework around a question. Okay, so they're basically a graph that shows you the relationships between variables in your in population. So how you believe your world is working, the relationships between variables in your study population. So you usually drag based on your expert knowledge of your study question. Okay, so all errors in a DAG are based on expert knowledge. We believe that is the way the world is working. And so it's actually kind of good in analysis to draw a DAG because you're actually providing your reader a framework of how you did your analysis. This is the belief that the world is analysis, and someone else could draw a completely different DAG for your world, and then you can argue as to which DAG is the most appropriate. But at least your reader knows this is where I am coming from. Okay, so the DAG for my analysis. So I'm sorry for all of the. These are the letters that you're going to see in any causal textbook. So is usually connotes your covariates. Okay. This is L at time 0. Okay. And then usually connotes treatment. So this is A at time 0. This is covariate information at time 1. This is treatment at time 1, and this is your outcome Y. This DAG can go way across the room depending on how many time points you have, right? So confound your C4, for example, at time 0 is going to whether or not at time 0. Okay, and your treatment at time 0 is going to predict whether your CD4 counts are at time 1, right? So if they count, they may be treated, right? Because kids do well, I don't treat right now. Granted, that's not the new recommendation. But choose to treat at time 0. CD4 counts drop, not treating at time 0 allows natural disease progression where CD4 counts drop. CD4 count dropped, oh boy, I initiate treatment. Does that make sense? Time treatment. All of these factors impact mortality. There's arrows from L, and CD count at time 0 predicts CD4 count at time 1. True, right? L to L1, based on CD4 counts, impact whether you're treated or not at time 1. And line CD4 counts predict mortality. So all arrows in a DAG basically show potential associations. The association in a DAG is when there isn't an arrow. So to draw arrows again with all variables with all of the other variables, right? So it's an unmeasured covariate, right? And this is where we have residual confounding. We just never measured U. We don't have it. Okay, so this is the world that I'm working in right now. Talk about, can I use stratification to be able to estimate a causal effect from this world?
I thought you didn't have to be there on you. I mean, they all
Sorry.
confounders don't depend on time.
It can. It can. It can. Say U is like underlying immune status, right, which affects CD4. So there could be a U for L0 too, right? So for this example, I'm just trying to show you an example of a U. But U's all over the place. And you should draw them all in. Okay. Interested in the cumulative effect of treatment, right? The effect of initiating heart versus not initiating heart. The cumulative effect of treatment. Not at time 0, not just treatment at time 1, not just treatment at time 50. We're interested in the cumulative, the overall effective treatment. Okay. And we see here that your C4 counts at time 1 impact we're treated or not at time 1. Right? Low CD4 counts, I'm going to treat you. High CD4 counts, I'm not going to treat you. And count at time 1 predicts whether you are done or not in that next interval. Okay. L1 here is a confounder. This is the definition of a confounder, right? Treatment impact we got to adjust for it. Do you? Yeah? Okay, good. If we don't adjust for it, we confound it, right? But L is affected by treatment at time 0. It's like on the causal pathway. at time 0, right? Do we like to adjust for things in the causal pathway? We should, right? Nope. Because if that's for L1, we may lose some of the effective treatment at time 0, right? That's not what we do. We're interested in the overall effective treatment. Boy, now what do? We have a problem. If we adjust for L1, what you end up doing is inducing selection bias. We end up inducing an association between treatment at time 0 and your outcome at time 1 through this way right here. Causal pathway. In language, L is called a collider. It is a common effect. And many papers have shown that if you adjust for a collider, you're adjusting for something within, first of all, it's good to adjust for something on a causal pathway. But if you're for something that's not just a causal pathway, but it's also a collider, then it would be introducing selection bias. So this is if we stratify on L1, which we know we need to do because it's a calendar for treatment at time 1, try to stratify on it, we're going to induce selection bias. We're like at a loss. Yes?
Sorry, can you explain how it induces selection bias?
Sure. So let me give you examples. I was at a board. So let's say we have Miguel Gibbs is this one. That A is rain. L is the grass is wet. It's rain, grass is wet. True? Is sprinklers are on. Sprinklers are next. If you fun, grass is wet. True? So that is a common effect, right? Use my sharp pointer. Are you working? Sure. Sure. I'm going to tell my boss that the pointer he gave me does not work. Oh. It's not working. Okay. Okay. Spring on. Great. Grass is wet. All right. Do you association between sprinklers and rain? No, right? All right. So on the grass is wet, right? So stratifying is within levels of L. Okay. So on the grass is wet, right? Okay, the grass is wet, and it's not raining. Whether the sprinklers are on, the grass, and it's raining. Do I think about whether the sprinklers are on? We know the sprinklers have to be on because it's wet, right? So we inadvertently induce an association between rain and the sprinklers by concentrating on the fact that the grass is wet. Does that mean I know something about whether the sprinklers are on or off by knowing that the grass is wet? So
The grass is white and it can be declined. It is all white.
the only two ways that the grass is wet. Yes, a dog could have peed on the grass. Absolutely. But world, right? Causal world, there are dogs that can grass wet. So in this DAG, right, could have had other variables here. Right? I would draw them in there. Absolutely. But regardless, there's another factor, right? There is still this association that can happen, right? There's one U. There could be another U. Here, right? But I have induced an association that is not real, right? I still have an association between two variables that are actually not associated. with each other. So this is bias, inducement association that just doesn't exist, and created by adjusting for something called for a common effect, a collider. And people like DAGs because it's easier to see when you have a problem, right? Common effect. We'll talk more about selection bias tomorrow. So tomorrow is about selection bias and adjusting for a collider. Text, we can't stratification because it will either adjust a previous treatment effect, right, because it's on the causal pathway, or it may induce selection bias. And I have to adjust for L1 because it's a confounder for future treatment. So what are my options? There are others, is to inverse probability weight. And you guys are compute the causal ratio using inverse probability weighting observational study. So you, all of you, are compute the probability had everyone been treated and had no one been treated under the assumption of conditional exchangeability. And you know the probability had everyone been treated and probability had everyone not been treated. We can compute a causal effect. True? The ratio. We just divide those two. Good. Are you ready? You pumped? Good. Okay. So let's go with a simplified observational study. I know HIV, so we're going to go with HIV. There's HIV-infected adults, CD L or confounder, and if L equals 1, CD4 counts are less than 200, which is immunosuppressed. Okay. A equals 1, which is our treatment, it being on heart or not, and AIDS or death, whichever one you like. And treatment status is decided after looking at CD4 cell count. So L confounder, right? It predicts whether you are treated or not. And assume in this simplified observational study that there's no loss to follow-up, because we'll talk about selection bias tomorrow. Today is about treatment. Okay. So that's summarized in a table, but let me put it in a tree so it's easy for everyone to see. So example, there are 20% of our population has high CD4 counts. So of the 500, we have 100 here, and our population has low CD4 counts. Amongst those with low CD4 counts, the probability of being treated is high, 90%, right? Which makes sense. If you have a low CD4 count, you're going to have a high probability of being treated. And 160 are following this here, this branch. And people that were treated in this, amongst those that were low CD4 counts, the probability of having AIDS was 40%. Here, 400 people in this branch, 350 got treated, and 144 got AIDS. Okay. Probability of not being treated amongst those with low CD4 counts is low, right? If you have low CD4 counts, you have a really low probability of not being treated with heart. So of the 400, only 40 were not treated. And the probability of having AIDS in this untreated group was really high. And so 32 AIDS cases. Okay. 100 with high CD4 counts, 50% were treated. The outcome was 30% in this group, and so we observed 15 AIDS cases. % in those who with high CD4 counts were not treated. And the rate of death is 6, so we observed 30 AIDS cases. Are we okay with this? We listen to the same 2x2 table that we had before. We good? Study population. This is what we observe. So, like I said, is to compute the effective heart on the risk of AIDS on the causal risk ratio scale. So, had everyone been treated, probability of the outcome had nobody been treated. Conditional exchangeability within the L. So first, I'm going to compute the probability had no one been treated, right? A equals 0. Compute the probability of the outcome had everyone been treated. Are we ready? Let's do it. All right. So this original data, we're going to do is those 50 people, remember those 50 folks over here? And say untreated. Okay, so of course, all 50 people. That would this arm right here, right? And make them untreated. And because conditional exchangeability, right? So we're going to force all those people to be untreated. And people here, we're going to make them all untreated. Right? Are going to be treated, and all 100 people are going to be treated. Okay? And conditional exchangeability, right? The outcome should be, the probability of the outcome should be the same, right? With levels of L, both groups are exchangeable, right? That is conditional exchangeability assumption, so we can do that. And apply the probability of AIDS, because again, the probability should be the same in both groups, conditional exchangeability. So how many outcomes am I going to observe? In this, had everyone with high CD4 counts been untreated? 60. All right, let's get in the 60, okay? Amongst those with low CD4 counts, if they've all been untreated, how many would not have had the outcome? 2,100 is 80. And 400 is 320, okay? We observed 6 cases amongst the group with high CD4 counts had untreated. We observed 120 cases amongst the 400 with low CD4 counts had been untreated. Okay? So let's say, had everyone been treated? Okay? So see that we're here, we push them down here. They're 40 here, we put them down here. Okay? And we conditional exchangeability, right? Apply the same probabilities of the outcome. So those with high CD4 counts that were treated did that AIDS. 70 of 100 is 70. And how many? Great. And then those with low CD4 counts, if they were treated, how many? 6% did not have AIDS. That's 240, and 40% did have AIDS. So that's 160. And I observe all of these outcomes. Observe them, but this is what we forced everyone to be treated, and we forced everyone to not be treated within levels of L, right? Conditional exchangeability. Did the pseudo population, right? You'll hear this word a lot. Pseudo population. Everybody with levels of L was treated and untreated. People treated, 100 people untreated. 400 treated, 400 people not treated, have their outcomes, right? So now population, which is basically twice the size than our original population, right? And so what do we do? It's probability weighted. What? We said it's inverse of probability of being treated given L, right? So remember, in our original data, what was the probability of not being treated in the high CD4 group? Does anyone remember? Yes. Our original data, 0.5, right? So what is 2? Is the probability of being treated, 2, right? There were 2 cases in the original study population, okay? Cases here. We did those 20 by 2. There's 40 in the pseudo population, okay? Again, there were 30 cases here in the original study population. we weight by 2, right? 60. In probability of being treated, given, right? 50% here, 50% here. This was also given a weight of 2. These were given a weight of 2. So in the population, we observed 70 here and 30 here, when it used to be 35 and 15. Okay. In this, in the low CD4 count, the probability of not being treated was low. Remember, only 10% of those with low CD4 counts were not treated. However, 0.1 is 10. So we're going to all a weight of 10, and we have 80 80 people did not get 320 did. Cases before here and 32 cases before here. We applied by 10, 80, 320. The probability of being treated amongst those with low CD4 counts was really high, 90%. 1 over 0.9 is 1.11. So we gave this group a weight of 1.11. Okay. So you basically just inverse probability weighted by everyone to follow within levels of L both treatment strategies. Okay. Yes.
So did we create the counterfactual
You just
because of
the counterfactual outcomes. Relations. Of magic. The assumption of conditional exchangeability, right? Because we apply the same probabilities of the outcome. Remember? So that's all inverse probability weighting is. And it's fascinating. So, yes? Okay. Probability being treated, this branch was 0.9. Let me show you the original data. So the weight was basically 1 over 0.5, right? 1 over the probability of being treated given L. Probability, okay, sorry, I said that wrong. Over the probability of receiving the treatment you actually got. Okay, so 0.5 was 2. Right? Branch received a weight of 2. 1.5 here was also 2. Branch received 2, so we observed 70 cases here and 30 cases here. Okay, in the population. 1 is 10. So we multiply by 10. So we observe 80 and 320 in the pseudo population. 1.9 is 1.11. Multiply these numbers by 1.11. You'll get a number of cases in the pseudo population. Yeah? Any good? So the branch of the tree, right? So it could have been L0 or L1. So you're going to do inverse probability weighting at each time point. Okay, so it's not just that it was the confounder or the computer. It doesn't matter. Okay. So whether it was L0 or L1, right? With probability weighting, you're not stratifying. You're not conditioning. Right? So you're just waiting. You're just waiting. Waiting the bias that we're worried about. We're just waiting.
So the argument making is that L is the only covariate really that matters in some sense, because on a clinical trial you're going to get the exchangeability is going to be the issue of the design of study in some sense. So here L, we think L is the only covariate that I'm really drive the whole thing.
Yeah. So this is a simplified example, right? In this example, I'm saying it's just L. And I estimate the probability of treatment under conditional on L and have my weight. Right? This is a simplified example, right? But this is essentially what you are doing. Right? This is it. All you are doing. First probability weighting. So this is only at one point in time. So just to get back at your question earlier, it's like this could be L0, but I can shift it over and make it L1, and shift it over and make it L2, different points, right? This example, we have one time point, okay? Population data analysis, very simple, right? Noting because everybody got treated and everybody got untreated, so there's no confounding happening. And counterfactual outcomes and probability of everyone been treated is right over 1 plus 310, so it's 0.38. The probability outcome had nobody been treated is 380 over 80 plus 120, which is 0.76. Hazard risk ratio is 0.38 over 0.76, which is 0.5. You guys did it. You compute the causal risk ratio using inverse probability weighting. I'm back. You did. That's it. That's all that was. Okay?
Could you go back to that chart again?
Yes.
So there, this is assuming that we don't have a randomized study, so we've got the confounding. If we had a randomized study,
there'd be no else. The probability of treatment in a let me ask you. So you answered my question. Well, this is a randomized study. What would the probability of A be? It was 50-50 weighted. Okay. Probability of A B under L equals 0. With coin as a 50-50 coin. Being B. Right? The probability of your treatment be under L equals 1. 50%. No confounding, right? The probability of treatment is the same. Equals 0 or L equals 1. There is no confounding. Why do we have confounding in this example? We have confounding in this example because the probability of treatment is different. Are more likely to be treated. If 5 and this is 0.5, we don't need confounding. We don't have to adjust for L. Right? No confounding. In population, do we have confounding? What's the probability of treatment in our pseudopopulation? Probability of treatment in our pseudopopulation? 50%? What is of treatment in our pseudopopulation? Everybody got treatment, right? Everybody got treated? Got untreated. Probability is 1 here, and it's 1 here too, right? So the probability of treatment is the same within the L. So we have no confounding in our pseudopopulation. Does everyone see that? We have because the probability of being treated is the same. Of L. That's actual treatment. Treatment, everyone been treated, right? So treated here, and everyone got. Then your pseudopopulation, then everybody walk through each treatment strategy. What inverse probability weighting created? Inverse probability weighting created a pseudopopulation, right? So basically weighted the people that you observed to create a pseudopopulation.
What does the consistency assumption translate to in this particular example?
So the consistency assumption is basically saying that what you observe, your outcome amongst the treated, is the same as the counterfactual outcome that would is the same factual outcome you would have observed among the treated.
So the assumption, I don't know, how consistent substance says that the probability of being treated cannot be
Zero.
zero.
That's positivity.
The positivity
Okay.
assumption.
So I'm going to talk about the positivity assumption. Basically, we can't wait if nobody who got a treatment, right? Like if the probability of a treatment strategy is 0, 0 is like infinity. So we can't, we need the positivity assumption. So a data set, you must have at least one person who does treatment strategy. Each treatment strategy under L. That's the positive assumption. Some of the book about cause and effect. That's right. Thank you so much. People went each treatment. Levels of L, right? With levels of L, each person went through each treatment, right? 100 people untreated, these people treated. Within levels of L, these 400 people treated, these 400 people untreated. It's whatever your confounder is. Could be 4 count at baseline, could be CD4 count at time 1, could be CD4 count at time, yeah. But between inverse probability weighting and stratification is that we're subsetting, we're not stratifying, right? We're just weighting people. So it's a different approach. It's like standardization, essentially, right? Just weighting people, not actually conditioning on people, stratifying on L.
So this is an estimator, actually. What you got is an estimate. So what you're estimating then will be the effect where?
So the effect, had everyone been treated, over the probability had everyone been treated, over the probability had no one been treated. So it's the marginal effect estimate.
Yeah, but this is with respect to which population?
This is study population.
In the individual that participated in the study, there's no external validity.
Sensitivity analysis, would you be changing the distribution of that L variable and carrying that through and seeing what it does with the causal estimate?
To see measured confounding
Yeah,
you would need.
if we changed L to 0.3, L0 to 0.3, and L equals 1, is that what you know?
It's not how I would do it, but I'm not that familiar with that type of sensitivity analysis. But this is actually, I mean, this is what you're observing in your population, right? So, like, if we can set L's and set A's to be whatever we wanted in our population, it would make sure that, like, there would be no confounding.
So that's not the way it's done.
I think do it from the end. Like, once you get your effect estimate, I would probably do simulation and try to figure out what it would take, what distributions of L have to be, right? Unmeasured L, another U, for example, would make that effect go away. Yeah, it's a break right here, actually, because I want to walk you guys through a real-life example. But let's just finish with this thing. What assumption did we make with our inverse probability weighting? What assumption did we make? Why take people that were actually treated, putting them into the untreated group? Right? We believe that we can apply the same outcome probabilities to that group. So conditional exchangeability in the population, given L. Exposure minimized within levels of L. So and we also are assuming no unmeasured confounding within levels of L, right? And so within levels of L, the risk amongst the exposed, if they were unexposed, is the same as the risk amongst the unexposed in the population, right? We're just applying those same risks to the exposed if they were unexposed within levels of L. So exchangeability, the observational study in the original population, a randomized experiment within levels of L, So in the pseudo population created by inverse probability weighting is a randomized experiment. Exposed and unexposed subjects are unconditionally exchangeable because they're the same people, right? Exposure is randomized, there's no confounding. So we don't need to adjust for anything because in the population, it's just if you're doing a randomized experiment. And the acyclic graph in a pseudo population. If you remember, I had said that it's the lack of arrows in DAG that's informative, right? So what we ended up doing in the pseudo population is removing any association between L and A. Quality of treatment is the same, right? Within L, across levels of L, actually. And so arrow. And arrow here, right? L cannot be a confounder of A. L predict treatment, L cannot be a confounder. Do you agree? If a treatment can't be a confounder. So for L, and move on to life example after the break. So let's take a 15-minute break and get back, and then we can go move on to a real life example. Yeah.
So, what consequences of randomization
Yeah.
However, the other way around, it's not an if in only statement, which means that if you balance well, you don't necessarily get this randomization give you good balance. But good balance might not necessarily going to give you this idea of randomization. In the sense that randomization give you more than good.
Yeah, so randomization, if it works, we're always saying,
Yeah.
if randomization works, right?
Yeah, but the question that I have is what is the procedure that we use for balancing, like the propensity score, we ultimately be on the day observed over dividing you.
Yeah, that's not true.
But I've seen many cases.
No,
where
no, that's not true.
That's,
It's not true.
yeah,
It has to be, you can't really separate it,
yeah,
because creating a propensity score is based on observed errors.
yeah.
So you can't believe that you have achieved balance on the honest observed errors.
Yeah, we just said randomization for observation study.
Yeah, but this is randomization.
Correction study.
Right, under conditional excusability. He's making this conditional excusability.
No, I think they can.
He is making
No,
conditional
he's
excusability.
I have a question. So when you're actually waiting, maybe a little bit after, with a bigger sample. So when you're waiting and this, you're going to end up having a bigger sample size. So, what if you have only 60 kids, 70 kids? Because they're going to very double kids.
But you have to adjust for the fact that you actually did.
Yeah. No, because I'm wondering, because like our cohort is only 60.
Sure.
Expectations is more than that, like
No, I know, but you're actually not increasing power because you're also increasing variability. So because the people that you did, right, your weighting is going to increase the number of people, right? Wait, one over the double depending on treatment levels you have. But all of these people are correlated. It's the same, right? So you're going to have to adjust for the variance. So you're not actually increasing power. For those of you that are here, can you access SAS Studio from your computers? Yeah, you were able to see the data set and the program? Get it? You could get it?
say the outcome to on the side. Yeah, I can get driving. I did do it. I did do it. So if you see,
Thank you. Extra space from the dash and my name, so there shouldn't be an extra space there. Is that correct? Yeah.
We need this today.
Yeah, just to run through the program.
I was trying to do something like, I was here.
I think you're supposed to shortcut.
Trying that not.
No, it's not running. Wait, here. Yeah, no, dash, whatever. So maybe I'll show you on my.
Yeah, you like it.
The user, no, the folder shortcut,
My name, but of course, we should add your name.
So how did I get here?
Yeah, so
Maybe I can show you this. So type this in. So to add this, yeah, so we just need to add the location. All right, people are back. So let's run because I want you guys to do some math. I don't like to do math in public, so I will make you guys do math in public. All right, just so you see the real life example of, okay. So everyone refreshed, happy to be back for the last 40 minutes. All right, so a very simple example of inverse probability weighting. And so I hope you understand what weighting is actually doing in one small time context. In reality, that was just one L, right? In reality, we have dimensional data with multiple L's, right? With multiple levels. Not everything is binary in this world. And so we can't really obtain meaningful non-parametric estimates of the weights, right? We have to rely on models. And so you rely on models to model ability of get a treatment you got, as the covariates, okay? And so what we saw in our example and what our colleagues to the positivity assumption is that if you have a very low probability of receiving the treatment you got, given your covariate history, you can contribute a really high weight. Right? Say, for example, in our heart example, someone with real CD4 counts didn't get treated, right? So maybe the probability of not getting treated is going to be like 0.01, right? So 1 over 0.01 is a very, very high weight, right? So you can have in your population some individuals with really high weight due to the relatively small probability of having their exposure given their covariate history. And so what we try to do is stabilize these weights. And we stabilize these weights by using the probability of treatment in the numerator, right? This is just math to stabilize people with really high weights, okay? And it's going to be these weights that we're going to apply to our outcome models. Not 1 over the probability of treatment, but you're going to put a number other than 1 in the numerator, okay? So what the stabilized weights do is basically just add a numerator that's very close to the denominator, so you don't end up with like these ginormous weights, okay? But it's really that it's essentially doing the same thing that the unstabilized weights is doing, which is getting rid of the association between your L's and your A's. Okay, so the numerator of your stabilized weight is essentially the probability that the subject received his or her treatment at week K, conditioned on their past treatment history and baseline covariates. Denominator is the probability that the subject received his or her own observed treatment at week K, given past treatment history and both baseline and time-varying covariates. Because stabilized weight, in the effort to try to stabilize it, right, and like decrease really weight, you add in baseline covariate information in the numerator, what we call V, which is basically just L0, right? In the numerator, the stabilized weights then don't adjust for baseline confounding, right? Based on the numerator, and then you put baseline covariates in the denominator, they cancel each other out. So your stabilized weights are going to adjust for time-varying confounders, but they're not going to adjust for baseline confounders. But because baseline confounders, and it's okay to put baseline confounders in a regression, right? You're not encountering the time-varying aspect of bias, right? Baseline confounders is just baseline. You can put those in your outcome model. So let me show you an example so this is a little bit more clear. But essentially, in real life, we don't use unstabilized weights. We use stabilized weights, where you have something other than 1 in the numerator. Yeah. Yes. Why baseline? Because if you don't, like, the goal of the stabilized weight is to minimize these really high weights, right? So if you have someone with probability of receiving a treatment, like I said, of 0.05, 0.05. And so you end up weighting these individuals really high. And so this is just people have said that most efficient way to minimize variance is to add the baseline covariate, the probability of treatment, and the baseline covariate to the numerator. So you're just to make the numerator look as much like the denominator, right? And one way to make the numerator look as much like the denominator is to add you have information on the baseline covariate, and you can go to your outcome regression model. So it doesn't matter, right? You're better. It's just you're about adjusting the time varying confounders. You actually don't have a problem with baseline covariates, and so this is just minimize that and make them look. I mean, if you did, you will have high weight, but you would adjust for baseline confounding, but the high weight cause a lot of problems. Some people have, like, someone was presenting at a conference one day, and they were showing the range of their weight, and one of their weights was just, like, in line with their weight. It was, like, unreal. And cannot do a weight. You know, so,
So you start 1, yeah, -1 and 0.
So this is, because you're going to, it has to be your past that predicts your treatment. So your founder information predicts treatment, right? So this is just saying that it's the probability of treatment given your past treatment history and your baseline covariance. Treatment given your past treatment history and your time varying L's. So it's just a lot easier so you can see what's happening. I talked about before is that actually don't remove this arrow with the stabilized weights, and so you're going to have to adjust for your baseline confounders. So how do we estimate this? So we estimate stabilized weights for both treatment and censoring. We're going to talk more about censoring tomorrow, but essentially what you're doing is fitting logistic regression models for treatment and for censoring, which we're all very familiar with, and then outputting predicted values from those models to calculate our stabilized weights. And then once we have our stabilized weights, we add into our final outcome model for heart on mortality, and we fit weighted pool logistic regression models using the stabilized weights. And for correlated observations, one method to do that is to use robust variance estimators, but you can also account for the correlation using bootstrapping and other methods. Yeah, calculating the propensity score. Remember, what is the difference between the propensity score and your inverse probability weight? Does anyone see a difference? There's another difference. So what is your propensity score? What is the propensity score? Probability of exposure. Probability of being exposed. True? Yeah. 1 over the probability of being exposed, right, would be the inverse probability weight for only the treated, right? So the probability weight is the inverse of the probability of receiving the treatment you got, right? For the people who are unexposed, it would be 1 over 1 minus.
So you compute propensity score, you're gonna get a propensity score for individuals.
For treatment. Your propensity score is the probability of being treated, right?
I mean, once you fit the model, I have a quiz that determines who gets exposed and not.
Absolutely. So
You're saying you have more government involvement in healthcare, when I think you have more private sector competition.
I'm sorry, not me. I love you again. I'm sorry, I don't know what that is. I don't know if we wanted to have. Let's just pretend that's not happening, because I won't go through this example with you. We have a half hour. So yes, you are going to estimate a probability from your model.
So you can estimate a probability for.
Right, and I just want to make the point that 1 over the propensity score is only the inverse probability weight for those who are treated in your population. For the untreated in your population, it'd be 1 over 1 minus the propensity score. If you're estimating your propensity score as a probability of treatment. Absolutely.
So what do you mean by 1 minus the propensity of one individual corresponding to another? That's what I'm trying to think.
So each person is going to get a weight, right? So the propensity score is an individual person's propensity, right? So for treated, so inverse probability weights actually are inverse of the probability of being, is the inverse of the probability of receiving the treatment you got.
Yeah, but what I'm saying, I'm not treated, and I'm gonna get a propensity score. To me, that would be the one I use to compute the inverse probability.
Sure. Model, like we model, what's the probability of treatment,
Yeah, exactly, yeah.
right? So that's all I'm saying.
Yeah.
Because you use the expression you are going to have a treated and untreated.
Yeah.
So we're looking at subcode.
Yeah. Yes. Example, just to go back to it, I was adjusting for age, sex, race, ethnicity, week of follow-up, and calendar year, and I had baseline and time varying measures of CD4 counts, total lymphocyte counts, white blood cell counts, hematocrit and albumin, and CDC clinical category, which is a measure of disease severity. All right, so let's go our SAS code real quick. So this now, I'm going to estimate the numerator of our stabilized weight. Okay, I'm going to model the probability of remaining off of heart. Okay, this is just to understand the probability that's coming out. And I'm going to do a probabilistic model. My population was called population O. And run this for when someone is not on heart yet, right? So for people that are not on heart yet. Because you're on heart, you're kind of always on heart, right? That's the assumption that I had made. So, and heart week is basically the week. I'll show you the way the data set is structured. But heart is essentially an indicator of the week that they started heart. And it's your week of follow-up. So this is my on heart is my treatment goal. It was 1 if you were on heart and 0 if you were not. I have a descending option here in Park Logistic. So it's modeling the probability of remaining off of heart. And baseline CD4 variables. This is baseline total lymphocyte count, white blood cell, hematocrit, albumin, and this is my week of follow-up. This is age, calendar year, and race and sex. Okay, and I output a data set, right, with my PID follow-up and the probability of remaining off of heart, right? And this is it's just naming that probability as part P underscore 0. The denominator of the weight is essentially the same thing, but I add in my time varying covariates. Okay. The numerator, except I have added in my time varying covariates down here. Do people see that? Okay. I'm going to put another data set and output the predicted values. Okay. First, going to model the probability of remaining uncensored, right? So I'm going to basically force everyone to not be censored. And so in the censoring model, I'm going to include treatment, because treatment can predict whether you are going to be followed or not. And the numerator only includes the baseline covariates. And the censoring weight includes treatment, the baseline covariates, and my time varying covariates, and predicted probabilities by week. Okay. So it's only your treatment and your baseline covariates, right? Stabilize the weight, and then your denominator is treatment. Yeah, right. Yes. The data is structured where it's one row for every PID week. So they can have multiple weeks, right? In a little bit. Okay. That's good for. So what you have from these logistics. Yes. You might always do a chart. You should always chart. I will show you. Is there like a set number that people consider to be No, this is where it's not clear, right? So some people like the rule of 10, where it's like if you have a stabilized weight, your stabilized weight could also have very extreme values, and some people will say, well, just cut off the weight, right? So if you cut off the weight, though, you're not adjusting for components, right? For some of those, so you'll have residual components in your model. Visiting then use like a real data from the ranking profile, and then try to yes, absolutely. There's many papers that have done that. I try to pull them up. Now we had our outputted data sets, Model 1, Model 2. These are our numerator predicted probabilities, denominator predicted probabilities of treatment, numerator predicted probabilities for sensory, denominator predicted probabilities. And then this is the original study population. So, I just the same. I mean, you can make up your own variable names, but this is the if you ever read Miguel's first paper on inverse probability weighting, he provides SAS code. This is essentially that SAS code. With my own variables put in, but these that he used, right? So I kind of just stuck with it because it's easier to cut and paste sometimes. Underscore 0 is the numerator of the weights. Underscore W is the denominator of the weights. And so this is just, I don't know, how many people are familiar with SAS? Good, everyone is familiar with SAS, right? So I'm setting for a new patient, so for their first PAD ID week, I'm just making these equals 1, right? And then I'm going to retain them, right? So each one gets carried forward, okay? So, and I'm going to show you the real data in a second. So the probability of censoring weights is essentially, this is numerator, right? So I'm going to multiply across time, right? So these for a person down. And then the denominator. Right? So I'm just multiplying down. For the not on heart, remember we estimated the probability of remaining off of heart, right? So it's just the same thing. These predicted probabilities were remaining off of heart. So I'm going to multiply down a week, right? For the people that started heart, right, the week that they start heart, it's going to be 1 minus that probability, right? And so that's multiplying 1 minus that probability because we had estimated the probability of remaining off of heart, and now they're on heart. And the people that have already started heart, we made that assumption. Once you're on heart, you're always on heart, and we're just going to carry forward their weight until they end follow-up. Okay. Stabilized weights, we just multiply the numerator of the treatment censoring weights and divide the denominator, the product of the denominator of the treatment and censoring weights. For the stabilized weights, it was just 1 over, right? So it's 1 over the denominator of the treatment and censoring weights. And then created these just if we wanted to only adjust for treatment or only adjust for time varying censoring. Okay, so but I just like them in there. Okay, so here's the sample data set, right? So here, this is one person. There was a follow-up. It was 18-week intervals. They start on week 65, right, until week 338. Okay. This is their these were output from the logistic model. Okay, probability of not being treated, right? It was done only until the point that they initiated heart, right? We had that where statement in the logistic model. To obtain the number of treatment weight, we just, for the first PID, it's just the same, right? And for the second one, we just multiplied, right? This times this equals this, right? This times this equals that, right? This is with the statement, remember, because the return statement is going to keep this number, right? And you're going to multiply by that, and you get that, multiply this, and you get this. And the week they started heart, right, it'd be this, where's my, this, to 1 minus this. 1 minus this probability. And that is equal to this. Carry that forward. We do it for the denominator, and we do the same thing for the censoring. It's just, we're just multiplying down, right? This is the first word. This times this is this. This times this is this. This times this is this. Okay, all the way down. And then we have our, let's do an example. If it has a calculator, we can do this. So what is the numerator of the treatment weight here? Someone said it. Great. What's the second one? Later. Great. As people are understanding what's happening. You Good job. Good job. And then the next one, let's do one more. Right. So you have to always look at your treatment variable, right? So because they started heart here, see, I like mistakes because it shows you, right? And so it shows you to always be as to when you start treatment. So minus. This is why we like SAS, because SAS will program it for us. We don't need to do this math by hand. And then we just carry these forward. Okay. Put from your logistic model. Yeah, that's it. So of remaining off of heart. So the person, 97% probability of remaining off of heart. It's the probability in the population of being off of heart in your past history, right? But this person actually started heart, right? You see, the probability of actually starting heart is really low in this person. At the time that they started, they had a very low probability of starting heart. It's changed. So in this data set, they're like at least for the logistics models, you'll see that their L's change over time, right? So your probabilities change over time, given your past. So this is the week that they started. So the probability of getting treated that week. This is the probability of remaining off of it. Right. But they, right. Well, now at week 39, it's going to be the same number because we're just carrying it forward. One heart, you're just always on it. Right, minus it. Yeah. What you're saying, but it's again depending on your past history, which can change over time. Right? Yeah, but given their, like, so the person that was, so this person is like, didn't have been treated, but they were, like, they have a very low probability of actually being treated, but they were, right? You need these people in your data set because otherwise you're going to violate the positivity assumption. Numerator, right? So they may actually not create a high weight because the denominator for this person is also going to be, right, numerator over the denominator. So let me just, so this is like, if you guys have issues with how the math is working in SAS, let me know. But this is essentially just multiplying down the probabilities that you're outputting from the model, okay? And they're just going to multiply these two by the multiplication of these two, okay? Create your stabilized weight. Okay? That's what SAS would do. And a statement in your pooled logistic regression model, because I'm trying to estimate a hazard ratio, so I'm using pooled logistic model to be able to estimate the, and I add this statement to add in the stabilized weights. Okay, because I didn't adjust for baseline, my weights don't adjust for baseline, I have added in my baseline covariates. Okay, so the results of my analysis, let me just go through it quickly. This is the crude model with no covariates, and you can see that there is confounding by indication going on. It looks like heart is bad for you, but with the confidence intervals, there's just no effective heart, right, on mortality. If I for baseline, it moves my estimate down to the expected direction where it's protective. And then if I use the weighted, you can see that pushed the effect estimate a little bit further to the left. So there, like, what do you conclude? There just wasn't that much time varying confounding going on, right? Like adjusted a little bit more. So it looks like baseline confounding was essentially like counting for most of the confounding in my study population. And a model that actually is the what you really shouldn't do, right? Which is add in time varying covariates to regression model, right? What you would be doing. This is a stratified approach. So see that it created a little bit of bias, not much to change anything, but this is you really shouldn't be doing, which is using regression to adjust for time varying confounders, ending of time varying treatment and time varying confounding. Assumptions, the assumptions were conditional exchangeability within levels of the measured covariates. In the paper, I wasn't able to adjust for viral load, but in that era, most decisions about initiating heart weren't actually reliant on viral load because a lot of the clinics didn't have it. But in recent years, it was. So the hazard ratio that I reported is likely to be underestimated, and of course, you have to assume that all the models were correctly specified. And I had concluded that long-term heart use is associated with lower mortality, and this supports the U.S. AIDS guidelines, and the results were comparable to the adult trial. And this is what we're doing. The study that I work on right now is a continued follow-up study where we look at the long toxicities of heart, and we look at different organ systems, and we look at growth and sexual maturity and all sorts of other things. So the funding sources for that study, MIT 32 at the time, and that's it. So let's go to SAS. I don't know how to do it. So what that I am showing that you have in your SAS studio is basically a subset of this analysis, but I included viral load in that. In that population. Okay, so there is, this is the program day one. So if you click it, it's going to open it up. Okay, so this is just, I mean, you all know SAS. So this is just the located, so I'm going to run that. And then that's just so you know what the format I'm applying, because I have it all categorized, all the different variables. And this is the data set. So I'm going to set the input data set, which is called new pop. And you'll see this is what the data set looks like. Have the way on this side, I think, for some reason. Yeah. So this is the numbers, right? Week of this is started heart. So this first person didn't start heart. The second person started heart at, I don't know what this is. Okay. At 78. This is their whether they died or not. This is the sun variable. The week started heart. So it's those who never started heart, and then for the weeks where you're on heart. Age, race, and onwards. Okay. So I'd like to do a plot contents just so you know what's in your data set. Variables that are in that data set. Okay. And then I like to always do just a quick prop print so I know what the data set's looking like. I just frequency of my different variables in my data set. So I restricted it to the last PID. The last PID is going to include the status variable, right? If I included the first PID, that's the baseline PID, I'm not going to know how many deaths I ended up having in my study population. And so I restricted it to the last PID. And to do that, I just did a quick proc freak to look at the distribution of the different variables in my data set. And you can see that of the 500 people in my data set, 302 eventually initiated heart. And week of heart initiation among the 302 people that initiated heart. And the final week of follow-up. So I ended up losing people across all time points. And I had 51 deaths. And 9 were censored. This is the distribution of age at baseline and all that. Okay, so I haven't run out of time. So, but I always like to look to make sure it makes sense. That a lot of these are what I would expect.
So is your analysis based on a complete data set, or do you deal with mixing covariates?
So I see data set. So this is a complete data set. Our proc logistic model for the numerator of the treatment weights. And again, we're going to only estimate probabilities for the weeks that up starting heart. So, and this is our proc logistic model. Because this is baseline, I try to just make sure that if estimates are going in the right direction, right? So estimating the probability of remaining off of heart. So I would say those who C4 counts are going to have a lower probability of remaining off of heart, right? And those who have higher CD4 counts. So this is going in the right direction, which makes me feel good. And then it's like those who are between 2 to 4 years of age have higher probability of remaining off of heart compared to younger kids, which may be a survivor type of effect. If kids are up to a certain age, they may not need treatment as much because they survived, so that might be a survivor type effect. And then for viral load, those who have high viral loads had a lower probability of remaining off of heart, which makes sense. And so it's just a good check. The first is always just a good check to make sure that you code things right and things are going in the right direction. This is the second denominator where I included the time varying covariates. A little bit harder to interpret because you have both baseline and time varying covariates in your model. So it's kind of a little bit harder too. This is your setting. This is the probability of remaining censored. So we can take a quick look and see if there are any associations here. If you treat it, you're more likely to remain uncensored. Is that the direction? Right? To remaining uncensored if you compare treated. I'm not sure I would have expected that, but that's that. A lot are not one, but this one is children at baseline who are 4 to 7 years of age likely to remain uncensored and censored compared to young children. So it's good to be able to just look at the output and see if I don't have many expectations with regards to censoring as I do with treatment, because I'm not quite sure what variable to predict someone being censored, right, or being censored. And this is the output for the model baseline and time varying, which was a little bit harder to interpret. This is the code that I showed you earlier to create the weights, and I'll show you the box plots. Okay, so that I showed you earlier to do the weights, and then I like to check to make sure that the weights are being calculated correctly by doing a couple by hand. So check to make sure. I check a couple of PIDs to make sure that the code's working, and this is a check to look at the distribution of the weights week, and check that most of the weights will be around 1. And so this is the stabilized weight, and this is the non-stabilized weight, and then you can look at the maximum, right? So it looks like a little bit, so this is by week. So at baseline, you know, everyone's looking all right. But then as you get like further and further into follow-up, you'll see that the weights start increasing over time. Look at this, for the non-stabilized weights, they can get really, really high. And box plot, it's a little bit easier to see. But you want it to be kind of centered around 1. So this is stabilized weights, and you see that they are centered around 1, but they're getting very, very variable over follow-up, because we're also losing people over time too. But the highest that I'm seeing so far is, I mean, there are some that are really high, but going up to 10, which is not so bad. But if you unstabilized weight, look at your axis here. You have weights that are like really high for your non-stabilized weights. So this is the stabilized one. Crude outcome model, not adjusting for anything except for week of follow-up. And we see here that hard with, well, there's not a significant association, but not in the direction that we thought. 18% increase in the hazard of death. This is the model, and see that heart associated with a decrease in the probability of death, which is expect. A lot of baseline confounding happening in this data set. We did model where you see the stabilized statement in here, the stabilized weights, you're adding that in. Move over to the left where it's now 0.27, it was like 0.4 or something like that. And then the outcome model where you include the time varying covariates as the regressor. So that's something that you shouldn't be doing if the causal framework that you're working under is that there's time varying confounding with time varying treatment. And you see the causal ratio, the estimated one from our marginal structural model was 0.27. This one is actually 0.39. And you would typically change your conclusion, but it's not the correct estimate. All right. This model, the weighted model, is called a marginal structural model because the parameters of that model, because you're creating the pseudo population where you're actually modeling counterfactual outcomes. And so when you're modeling counterfactual outcomes, this is considered a marginal structural model. Or now you're not adjusting for your time varying confounders, although you're still conditional on your baseline one. Okay, 3. I was supposed to leave room for questions. So does it have any questions? I'm happy to go over. I'm sorry that the last part was kind of, but if anyone has any questions about this, just feel free to email me, and you could play with the data set a little bit and see how the data is structured. I think the data structure is a little bit the part to get right. You know, like it's a harder part to do, is to make sure that it's structured properly. The easiest thing to do is finally just to run the model. You know, it's data structure part that's a little bit tough, but as long as you know how things are related to each other, you can do it.
So we're using this data set tomorrow?
So tomorrow is the selection bias example, and it's a different case study. So in that case study, we didn't worry about time varying confounding, and so it's more of a pregnancy type outcome type thing. So it's not, you don't actually have to worry about time varying confounding, but we have to worry about selection bias. All right, thank you. I hope it was helpful. If you have any questions, again, please feel free to email me. Oh, good. I'm so glad. I'm so glad. Hi.
I'm Ken Wilkins with ADK. I'm kind of hoping the in-place host, not so much the organized segment, but
Yep.
we set you up that you would host that WebEx. Look, we're trying to get out, but it still shows a recording on my
Good.
end.
I'm glad. I didn't know what was happening, so I don't. I didn't set anything up regarding WebEx. I just started.
It's still recording now,
So I have to be careful what I'm saying.
but I would have, I would have stopped it for you, but you're the host.
You can communicate, yeah, because you were sharing your screen.
Okay.
So just go to,
Stop sharing. Is that right?
you can go to participants, actually. What you
Uh-huh.
want to do is right on me and say, make them change room, host, roll back on my cord, I can stop.
Great, thank you. I didn't know that this was happening. Yeah, so that's fine.
Yeah.
Well, I don't understand my statistician, I work with clinicians or the doctor. And so, like, you do a study with somebody, you're sitting down with the doctor.
Diagram is great because it shows you, it helps you draw your DAG. I'm talking.
Yeah, but it's not recording, it. We'll just shut the speakers off.
Okay.
You won't have to hear yourself.
So
It's called DAG.
it's called DAG. And let me see if I can pull it up for you. What a DAG allows you to do is to identify the minimum set of covariates that you need to measure to adjust for confounding. I mean, it's just like the best reason to draw a DAG, and it's also a good reason to draw a DAG is to just so your readers are aware of the framework that you're working under. Because you may agree that this variable is associated with this, right? Experts disagree on things all the time. And so, but at least, so you can say, this is the causal framework that I'm working under for this analysis. Just to disagree with it from the beginning, at which point disregard what I'm telling you. But, you know, if you think it's a reasonable causal structure, then that's just the way I did my analysis. You can also choose to draw. This is why, like, reproducibility in research is really important, but it's really hard to know if studies are trying to ask the same question. They didn't, like, really specify it well for you. You know, and having a DAG is very easy to say, oh, these two studies are trying to get at the same, and this is the assumptions that they made, that this variable is associated with this variable, and this is why they adjusted for confounding the way that they did. I don't necessarily agree or agree. You know, so it's just you're giving as much information as possible to your reader.
Well, so the context that I'm working in is we do, for diabetes, we do large-scale clinical trials, all funded by NIH, diabetes prevention program.
Oh, okay.
So,
in education, okay.
I work
Right.
with Jeffrey Coppett at IPW.
Yeah, I work with them on some APL.
Yeah, me too.
Yeah, okay.
Me too, with it, but in the context of HIV, I did.
I work
Yeah.
with HIV.
He's so great. I love him so much. He,
Yeah.
like, really challenged me a lot, and he really, like, he came on to my life. But,
Oh,
he,
yeah, okay. That's great to know that you're exposed to this stuff, then.
for the one, for genotypes, it's, you know, like, you don't randomize genes, and so, nature does it for you, I guess.
Yeah.
And so we didn't really have to do much for that. But, he's, I just love talking to him. He was, like, he always had these very, we actually did draw, yeah, and I had to draw a DAG for him.
Yeah,
To
okay.
help him explain why we adjusted for race.
Boom. Then, yeah, then you get into the causal
Yeah.
effective race, or is it really the genotype
Is it
that
the
ranks
genotype
the
that
proxy for? What that says, it might not be, yeah.
Exactly.
Yeah, the
So we
usually.
adjusted for ancestry and informative markers.
Okay.
And
Good
so,
marker, you were,
yeah.
okay.
Great. It was,
We're getting geeky here.
yeah.
No, so.
I gotta know that stuff too, so.
So in my, so in a clinical trial, basically you have the exchangeability. baseline.
The intention to treat analysis, so in
Those things I'm trying to understand better. And then the other piece is that, so there's any interest in showing causality in a lot of these things. I mean, a lot of people will have some, like, we got a ton of data and stuff that people don't have. It's awesome, but some of the questions, you know, about what actually causes what are still, you know, they're still developing their knowledge. So then the question comes, we're going to do a study of our randomized population, but we're only going to take subsets of that. And then all of a sudden, you can't even do baseline anymore because you might have an imbalance.
Yeah, if you're going to do a subset of your randomized sample, you don't know whether you're unmeasured.
Right.
So I like epidemiology because it's fun. It's not as simple as a randomized trial, but randomized trial is not simple anyway.
You guys on here and follow up with that outcome opportunity, it becomes an epispective where you only, you have an instrument as randomized, but.
And happen. Yeah. So the trial stuff is really cool, but I think also, it's always fun to think about like post-study things that may be happening, over time.
So Daggity.
And Daggity is fun. I mean, it's just a way to draw relationships between your variables, and then it gives you it has these tools where it'll say, because there's rules for DAG in terms of like, how do you identify whether there's confounding happening? How do you identify
That's built into that.
And in Daggity, it'll just say, oh, they know how to identify all the vector counts. They know how to identify all that. And so it will, all the rules for DAG, all the separation rules, they just say it. And it starts with like a minimum set of covariates that you can measure and adjust.
So you input into Daggity your outcome, your covariance, your baseline,
And how it's related.
and how do you specify that?
It was like a descendant or antecedent or.
Yeah, they have a markup language for that. That's what I'm.
Really cool.
I was thinking we could, you know, in terms of software toolkit.
Right, this is what is this? This is exposure, right? That's your outcome. Exposure is affecting Z. But you can change, so you have ancestors, your outcome, this is another variable. So this is a consequence. So like, you know, you can change all sorts of and stuff like that. I forget how to use this. I'm a hand drawer, but there's ways, and so it shows you, right? Like A is independent of B, right? A is independent of D given E. B is independent of E, and it's necessary to estimate the total effective E on D, right? So, they've added different things here too.
And it even exports our code. It looks like right here.
I want to get this, let everyone, there's different artifacts for that model, so.
Wow. Okay.
So it's just fun to play around with and just kind of.
This is commercial software, you purchased it?
No, it's online. This is free. I just Googled it.
And it's servers on client side?
I didn't download anything.
Yeah, okay. So does it have a markup language underneath it though, or like that's?
I don't know.
I'll look at some retrievable.
Yeah, you can write it. Yeah, but it's really like it's just a fun and they have draw DAGs and then identify,
So too,
if you see
collaborators too, if they have some sense of,
right.
they have a starting sense but aren't like experts at deseparation for them. Like,
Exactly.
then you could get them started on this on their own, and then do their homework before you come in to meet with them.
There's
Has that
daycare
ever
that has
happened?
to happen. No, we do a lot of adult daycare in my work, but it's great because it helps. I actually prefer talking out what everyone's saying. Like I want to know where you're from.